Welcome, everybody, to our first UEFA medical webinar after a brief summer break. We're about to kick off again a full new year of what we think are great topics for a medical webinar. And I think we picked a nice one for the first one to kick it off again for another season, which is oral health, which goes beyond dental health. I've been told, and you probably will be told the same today. This is an important topic for us because it's new for us to dig into. It's also an important topic to dig into. And we are going to put a bit more emphasis on the topic of oral health for the next season and the forthcoming season, which I will explain to you a little bit after we had our presentations today. May I welcome to the stage Peter Fine and Sol Conviser, our speakers of today. Welcome, Peter and Sol. Thank you for your time and thank you for your presence today. I'm really looking forward to what you have to share with us. And this is a topic that we hear about in the literature every now and then, and we hear that it's very important for us to have a good look at, but also a topic that's a little bit of a blind spot for me at least, and I can assume for many of our colleagues within the football realm. So without further ado, I'll give the floor to you, and then I'll be quiet for a few minutes.
So thank you very much indeed, Evert and Zoran, for inviting us to come and talk to your colleagues today. It's a real honour and a pleasure to talk to you all. Firstly, by a quick introduction, I'm Professor Peter Fine. I'm Professor of Dental Education at UCL Eastman Dental Institute, and I'm also the Director of the Sports Dentistry Oral Health in Sport Master's degree, which we run at UCL on an annual basis. So what I wanted to do today was to talk to you a little bit about oral health and athletic performance. We are acutely aware that athletic performance is built up of many, many different aspects. And oral health definitely forms part of that. And I'm going to show you some evidence in the first part of the presentation today that will hopefully illustrate to you how that evidence about oral health influences performance of athletes. And Saul is going to talk a little bit later, particularly about football studies that we have been looking at over the last few years. We're going to do a little bit of an introduction to oral health and how it links with systemic health and athletic performance. I'm going to show you some evidence through the research that we have done locally in London and across the world. And then we'll look at some oral health strategies in football and the role of the sports dentist and how that can help you as sports medics with looking after your elite athletes. Next slide. So I think just to start off with, what I wanted to do was just to sort of define one or two things, because oral health is slightly different from dental health in that it's much more inclusive. And oral health is really to do with the mouth, the teeth, oral facial structures generally, and those that enable us to help us to function properly, eating properly, breathing, speaking, and more now encompassing psychosocial aspects and self-confidence. And I'm sure you'll be very aware that confidence is a huge part of elite athletes' performance. And we're also going to look at athletic performance and define that as the ability to execute specific movements and tasks within a sporting context. And this sort of demonstrates a combination of physical skill, mental focus, and strategic thinking to achieve the outcome that we want to will have athletes to achieve at the end of the day. Now, what I wanted to do, just to introduce the topic, is to run through a little bit of dental anatomy. So I think this is going to be important, because to understand how disease in the mouth works, you need to know a little bit of the anatomy. So the picture on the left-hand side of your screen shows a standard illustration of a normal tooth, a healthy tooth. And you can see at the top third of the picture, we've got the crown of the tooth, which is enamel and dentine. And these are the sort of hard tissues. In fact, enamel is the hardest tissue in the body. In the middle of that, we've got a sort of red and yellow and blue area, which is the pulp, and leading into the root canals. And this is the blood and nerve supply that each tooth has in a healthy state. The important area for you to have a look at now is what we call the gingival tissue, the gum of the tooth. And this is supporting the tooth within the bone via what's called the periodontal ligament, which you can see illustrated on the slide here. And this is hugely important, and we'll see later on why so, because disease of the gum is very, very prevalent in athletes that we look at throughout the world. The nerve supply of the tooth is also very important, because this gives the tooth vitality and life. And when it becomes diseased through either dental decay or maybe through trauma, then we can get a problem with that nerve, and treatment has to be done, which may involve some extensive work on the tooth, or may even involve extracting the tooth. The image on the right-hand side of the screen illustrates the bone level in a normal, healthy situation. And that's important for us to visualize this evening, because that level of bone during disease can drop and cause the tooth to be less well supported, but also to arrive at a situation where bacteria can get into the pocket that the bone leaves and cause more and more deterioration of that bony union between the tooth and the periodontal ligament and the tooth. So next slide, please. So here, just some things we're going to look at this evening. We're going to look at dental caries or decay, and you can see on the top right-hand image some quite badly decayed teeth that need extensive treatment. We don't always see images as bad as this, but this is just to illustrate what can go wrong. We also, on the bottom left-hand image, can see some periodontal inflammation and disease of the gum around the teeth. And this red, swollen, bleeding gum is not normal, it's not healthy. But we do see this a lot in the athletes that we look at throughout our courses and work. Also, what we're now beginning to see more and more is both abrasive and erosive tooth surface loss. And erosive tooth surface loss is particularly as a result of acids in the mouth, and these can be intrinsic acids or extrinsic. And we'll talk a little bit more about that as we go through the presentation. And finally, we'll look very briefly at dental trauma, because there are episodes where trauma to the teeth can result in damage to the nerve of the tooth and resulting in the death of that nerve, which can cause an infection and affect the athlete as a result of that infection. So we'll talk about these 4 aspects this evening. Next slide. What I want to do just briefly now is to look at oral health in its context throughout the whole body, really. And if we start with the nutrition is clearly extremely important to all of our athletes. And by working with the athlete to develop the nutrition that is best for each one as an individual sports that they may be doing, the nutritionist is trying to get to the optimum peak performance for that athlete, whether it's a footballer, a cyclist, a swimmer, or a track and field athlete. So nutrition is very important. It's also important for us as dentists, because we know that diets high in carbohydrate and high in sugar do cause a lot of decay and inflammation of the gum and the gingival tissues. We're also acutely aware of dehydration. and the fact that lots and lots of athletes will drink sports drinks. And we'll talk a little bit about that as we go through, because we're concerned about the acidity of the sports drinks causing erosive tooth surface loss. Access to care is also very important. We recognise the fact that athletes, footballers included, are travelling or training or playing and don't necessarily have much time to get to see a dentist on a regular basis. So access is extremely important, and sometimes we will only get to see them when there's a problem, but we'll talk a little bit more about that as we go through the presentation. Also, we know that athletes who are training extremely hard can get immune suppression to their systems, and this leaves them more vulnerable and open to infections. Awareness is interesting aspect, because we know from discussing with the athletes and footballers included that they are extremely aware now of the aesthetic aspect of their teeth, but may not necessarily be quite so aware of the health aspects, which is where we come in and help them out with that aspect. And finally, what links in with oral health is health behaviours. And I'm sure as clinicians, you are extremely aware of how difficult it is to change our patients' health behaviours. And this is something that a colleague of mine, Julie Gallagher, has looked into a lot and has written quite a lot about how we should go about changing behaviour of our elite athletes. So where's the research? What does the research show us about oral health, systemic health and athletic performance? In this study, which was done in Germany by Merle et al. In 2022, they looked specifically at oral inflammation amongst athletes. And they found that the gingivitis, so this is inflammation of that gingival tissue, affected between 58 and 97% of the athletes that they looked at. A huge number of athletes. While periodontitis, which is the progression of gingivitis into some bone loss around the teeth, also affected a large number, approximately 41% of the athletes that this particular study looked at. Quite a lot of them had oral pain as well, and between 3 and 9% reported that negatively impacted on their training and performance. And it may well be that you can relate to that in terms of some of your athletes having missed training or having had a deterioration in their performance as a result of pain from an oral health infection or problem. We also now know that the systemic effects are evident as well. So periodontitis is linked with changes in blood parameters and reduced physical fitness. We also know that poor oral health is associated with injuries, including higher rates of muscle injury in these elite athletes. Next slide. Now, in this study that was done by a colleague of mine, Jacopo Butti in London, he looked at, in fact, law enforcement officers in England and looked at their oral health and periodontal health index along with their physical fitness. He looked at 89 recruits and he looked at cardiopulmonary fitness, and that was measured by VO2 max levels, and he looked at maximum load and generated the end of the Bruce incremental treadmill test. So he looked at these sort of power and these strength tests that are commonly done with athletes. He found that, in fact, oral variables including percentages of sites with periodontal pocket depths of greater than 4 millimeters were indicated a much greater loss of their physical fitness. And 4 millimeters depth of pocket, so that's the loss of that bone around the tooth to a depth of greater than 4 millimeters, is seen as being an area where the disease has caused unrepairable damage. And so therefore these teeth are less well supported and more likely to get more and more problems as they go along. The periodontal pocket depth of greater than 4 millimeters, whilst not being statistically significant, was consistently correlated with lower load max as well. So these athletes were able to perform not quite so well when their periodontal health was reduced in this way. Next slide. Now, this was a slide, a study that was done by Needleman, Ashley and myself a few years ago now in 2015 in London. And it was a systematic review, and we looked at poor oral health causing pain, and it negatively affect on appearance and the psychosocial effects on confidence and the quality of life of these athletes as well. Many of the athletes reported evidence that suggested that their oral facial pain and so on had an impact on training and performance. They also realized that that competition and training had been affected as a result of pain and inflammation that they had in their mouths. The evidence goes way back to 1968, but in fact, it wasn't until London 2012 that we really started to collect evidence about how oral health issues can affect athletes and their performance. So the contributing factors were high sugar levels in the diet, oral hydration or dehydration, the immune suppression, and low dental awareness. Poor behaviors, that is poor use of oral hygiene aids that Saul will talk more about in the second half of the presentation, and really a lack of prioritization of oral health by the athletes, but also by those individuals looking after the athletes as well, basically through not knowing what was needed. The shame is that oral diseases are largely preventable, and this is very simple evidence-based interventions can be used to prevent the decay, the gum disease, the erosion, and so on. So we came up with a consensus statement, and it called for greater awareness, preventive strategies to be implemented, and health promotion, and more research in elite sport, which is ongoing. So we now go on to look at oral health and systemic health, because there's now quite a bit of evidence to show that actually, particularly things like heart and lung disease can be as a result of poor oral health, particularly things like rheumatoid arthritis as well. Alzheimer's has been linked with poor oral health, and some metabolic disorders as well. And also from this study that was by Panthak, came out of China, further correlations between oral disease and pulmonary disease could suggest a possible role of oral microbiome in respiratory diseases like COPD, pneumonia, and even lung cancer. So this is quite important, because if we're looking at the health of our athletes overall, then we need to be extremely careful that they don't get any of these rather serious systemic diseases. Equally, there are now links between oral health and liver disease. And this comes about because of the possibility of pathogenic bacteria that live in the mouth being swallowed or entering the bloodstream. And if you think in terms of the gingival tissues bleeding, then certainly bacteria from the mouth, which are normal commensurates in the mouth, can get into the bloodstream and lead to a dysbiosis and increased gut permeability. And this can result in inflammation and fibrogenesis in the liver and ongoing liver problems as a result of that. Next slide. So a little bit of epidemiology. We looked at the 6 studies here, looking at the 4 things that we've highlighted this evening: and caries, erosive tooth surface loss, gingivitis, and periodontitis. And the first study, which was done, as I say, in London 2012 Olympic Games, we could see that almost 50% of the athletes that we looked at, there were just over 300, presented with decay in their teeth. A high proportion had tooth surface loss as a result of erosion. 3/4 of them had gingivitis, and 22%, nearly 1 in 4, had irreparable periodontal disease. And these are in a demographic of people that are 18 to 30, should we say, should be in the prime of their life. Certainly from an athletic point of view, they're in the prime of their lives. Similar results were obtained in the Rio Olympics in 2016, and similar results from a systematic review done a few years ago, 2014, showed similar results. The study on English professional football, which was published in 2016, showed similar results here, with over half the athletes that we looked at. There was about 180 athletes that were looked at, had some sort of evidence of erosive tooth surface loss, and gingivitis, 80%, 5% having some periodontal disease. And then the English Football Academy study that Saul and I did and published early this year, which he will talk about more in a few moments. And these are young academy players between 16 and 18 years of age, and over half of them had decay in their teeth. 2/3 of them had some erosive tooth surface loss. And this is important because these players now have got to have some sort of treatment for the rest of their lives. They can't grow back that tooth tissue that's been eroded away, particularly the erosive tooth wear. These need to be treated on a comprehensive basis as soon as possible. And once again, 3/4 of them had gingival disease, and almost a quarter of them had periodontal disease. And I just put the figures at the bottom for the Adult Dental Health Survey in the UK, which was the last one done in 2009, by way of a comparison. So you can see that our athletes do tend to have more disease than the average population. Next slide, please. So what we have often asked the athletes is how they feel about this. And in London at the 2012 Olympics, 18% of them reported that they felt their oral health had impacted negatively on their performance. In Rio, we found that 9% of them thought that. The English professional football study, 2016, 7%. And in the academy football study published earlier this year, we found that 10% of them, the players, felt that they had that their oral health had impacted negatively on their performance. Next slide. So a little bit now more specific about football itself. Next slide. So the press do get hold of things and magnify things for sure. But this is a very common thing that we find. This footballer now plays at Manchester United, and he had a huge problem on the way to a match. So he came out with this phrase that was then put in a press in England. You don't think your teeth are going to stop you from playing football. It did actually really mess me up. It was Newcastle away, that's Newcastle United away. And I woke up on the day in agony. I was in the car back to London, and it was the worst journey I've ever been on. I wanted to just rip them out myself, but it wouldn't have been the best idea. And this sort of illustrates just one story, and there are many stories of these sort of incidents that happen to players because unfortunately they haven't sought the care and help that they need before they get a huge problem like this. Next slide. So, oral health in football, what does the research show us? Well, this study was done in Barcelona in 2011, and it looked at professional footballers from the Barcelona club in its relation to the incidence of sports lesions, so sports injuries. And they found moderate levels of untreated decay or players that had decay experience. And by that, they mean players that had actually had decay treated. So they had either fillings or some sort of restoration in their mouth as a result of the decay. And they had oral inflammation, was widespread. 30% of them presenting signs of parafunction. This is sort of grinding their teeth and clenching their teeth, which is a sign of stress. And statistically significant link between poor oral health and muscle injuries. Now, the oral examination before the beginning of the season was suggested by this article. And this is something that we're following up on now, and we are suggesting this continuously, that these athletes need regular oral health checks, normally as part of their pre-season training. Next slide, please. The Needleman study that looked at professional footballers in England, and they had 187 players, which represented more than 90% of each player's squad, so very representative sample. And once again, you can see very similar data here, over 50% having erosive tooth surface loss. 80% of the players had inflammatory gum disease, gingivitis, and periodontitis. 45% were bothered by their oral health. And I think that says a lot, so that the players actually realise that they have something going on that's causing them some problem. Next slide, please. And just a little bit about some of the results here. We found that actually 16-17% of these players hadn't been to the dentist for between over a year, and some of them for more than 2 years. And we looked at the frequency that they drank sports drinks, and we can see here that actually over 40% had between 3 and 5 drinks a week, and almost 1 in 4, nearly 25%, had over 6 sports drinks a week. And this is what we contribute the large amount of erosive tooth surface loss to. Next slide. So this slide was done in Belgium, Holland, and the UK, and it looked at players that wore fixed orthodontic appliances. So this is appliances to straighten teeth. And it comes back to the point I was making earlier, that players now have got very much aware of the aesthetic aspects of being in the media, but actually maybe the health aspects are something that needs to be looked at a little bit more seriously. And in this study, they found that actually players who had worn orthodontic appliances had some level of imbalance in the way that their bite was, and this potentially caused more injuries to them. So this is an important finding, because what happens here is that if there's an increased level of gum disease, increased level of caries, and an increase in terms of the way the teeth are working together, then we're almost sort of putting these players into a very serious position. Next slide, please. So periodontal health now, and this study was done in Portugal. This Botelho and his group looked at 22 professional footballers during 2020 and 2021, and they found periodontal disease in 41% of the group that they looked at. There were more non-traumatic muscular events in the past 6 months with these players, and this is it gives an indication of how perhaps periodontal disease and gingivitis are giving some sort of inflammation to the system generally, which is resulting in some sort of muscular injuries to these players. And it's quite an alarming prevalence going on with this sort of disease. Okay, so at this point, I'm going to hand over to Saul, and he's going to talk to you a little bit more about some of the football studies.
Great. Thank you very much, Peter. And thank you very much again, Evert and Zoran, for inviting us to join this this webinar. It's a real privilege to be part of this and speaking with your colleagues here. Just by way of a very brief background, so I'm a general dentist working in practice in London, as a sports dentist as well, having studied with Peter at sports dentistry at the Eastman, and also conducted research with him, which we'll come on to in a moment. So just to bring us up to speed in terms of the latest research published this year, most recently, Angelillo, at the start of this year, in fact, from southern Italy, looked at the oral health status and the impact of oral health on professional footballers in Italy, and its impact on their well-being, their quality of life, and their perceived performance as well. 160 players, professional players, participating in the study, with high rates of dental decay or dental caries evident, also high rates of dental erosion, about 48%, which again correlates with the figures which we've seen in the previous studies as well, with a strong association with sports and energy drink consumption in these players, and also very high rate of periodontal disease. So there's actually bone loss and attachment loss around the teeth. Also, over 30% reporting pain from the mouth, so not just the teeth, but the mouth as well, and that this does affect their daily life, so their quality of life, their well-being, and the players also report that they believe their oral health negatively impacts their performance, and again, highlighting that there is a need for preventative programs to be implemented in this cohort. Next slide, please. So earlier this year, Peter and I published a paper when we looked at the oral health status of academy football players in football professional academies in England. We also looked at their perception of the impact of oral health on their sporting performance. And we looked at 160 players. We had 16 to 18-year-old men's and women's from academy clubs representing the Premier League, the Championship, and the Women's Super League. And what was very interesting, actually concerning as well with this, the findings, there was, for such a young age group and cohort of athletes working and playing in professional academy setups, was to see such high rates of oral disease. And this included dental caries and dental decay. There was over 50% of the players that we saw had a history or had a high DMFT, so history of decayed, missing and filled teeth. So teeth that had been filled or removed as a result of decay. Over 30% had active decay that we saw during the time of the screening that required treatment. And again, fitting with the trends that we'd seen in previous studies, alarmingly high rates of gingival inflammation, so gingivitis, and up to 23% had periodontitis. That's irreversible damage to the supporting structures around the tooth. And particularly for such a young age cohort, that is what was quite surprising to see. The other surprising one figure which we saw was the high rates of erosive and abrasive tooth surface loss. And I know Peter mentioned it before that in part we can put it down to acids, and this could be dietary acids in the form of different types of drinks, energy drinks, sports drinks, which we'll come on to later. Also gastric acids, reflux, things which we did also see as well, patterns, indicating patterns of, but also the pressures and the stress that a number of these players are under at the 16 to 18 cohort to be fit enough to be able to play, to perform at the highest level, to progress with their career. And we're seeing tooth wear as a result of grinding of their teeth. And again, we will come on to this later. But for such a young age cohort, we were seeing very extensive levels of tooth wear. And this is something which fits into the overall bigger picture of looking after our players' well-being, as well as not just their oral health. A number, over 20%, hadn't been to a dentist for over 2 years. Again, they're being looked after in fantastic medical facilities, in their training grounds, etc. But the dental aspect was not there for them. And there was a common perception amongst the players that they did believe that their oral health did negatively affect their sporting performance. And as we mentioned before, we have epidemiological studies looking at national population, and it did show that the oral health of the academy players that we were looking at is higher. It's more evidence of oral disease in this cohort than that of the national population. So, is indicating that there is, again, further need for oral health education and promotion amongst this cohort. Next slide, please. So now I just want to start going into giving some more practical advice that you can take away from this and start implementing yourselves with your clubs, your players and your teams. There's a number of elements, and I will introduce them and apply them to different things which we talk through. But we know, of course, oral hygiene, the importance of looking after the mouth with brushing and flossing and things like that, which we'll come to. Nutrition, as Peter mentioned, of course, we are not here we're not telling patients to change their diet. We're not advising on what not to do. What we are trying to do is add to how we look after their players, because the nutritionists and the dietitians, you have your programs which you very specifically cater towards your players and their performance needs. So it's ensuring that helping you understand how that can impact on their oral health and how we can support you to further support your players. Other things such as dental screenings, which we will come on to and we include as part of our research, is a very important way to be done pre-season to enable early disease to be picked up early, and to identify any problems and implement change. Dental attendance, this is of course something which, as Peter mentioned, access to care is very difficult amongst this professional players with their time commitments, the travel and things like that. So we need to work around their diaries and factor this in, but it's important that they understand and the teams understand the need for players to actually be attending a dental practice, so things can be looked at in detail. And of course, behaviour change. This is a very difficult one because whilst we can tell patients and players that they must brush their teeth more frequently or better, we need to change attitudes and their perceptions and their understanding of how it impacts them. And this is something which, together as a collaborative approach between sports dental team, and that is the dentist, the hygienists, the whole team working alongside the sports medics and the nutritionists and the physiotherapists and the whole sports, the football medicine teams, is very, very important. Next slide, please. So just to briefly touch on screening at clubs. So this is something which clubs can absolutely, implement across the board. Of course, there are certain things which need to be factored in from a logistical and administrative point of view. And we here in the UK, we use a toolkit developed by the UCL Eastman, where Peter works, which gives very clear sort of guidelines and protocols that we follow, which allows us to, work, again, firstly, in the best interests of the players and the clubs, to ensure that it is an effective and an efficient system which everybody's going to benefit from. When we were looking at the young players, of course, there's things like consent, which needs to be required, and sometimes from guardians. But also, we don't want this to interfere with the already extremely busy schedules that exist for football players. A lot of clubs often do their pre-season screening, and maybe it's factoring that in. And of course, we need certain amount of times, and whilst limited facilities such as a physiotherapy table, it is space which could clubs often use for other things. So we don't want to interfere with existing routines and practices. But in addition to this, I think it's also really important when we do the screening that it's not just identifying issues and then we go away. It's actually, we provide post sort of outcome reports on our findings, which then go to clubs, to the medical teams, to the sports scientists, to the physiotherapists, so they can signpost appropriately to their players and to the medical teams to ensure that these players are being looked after. And our duty of care is to look after their players, and if we identify an issue, that does get addressed and it's not left unattended to and something which could become worse. And then, of course, when we do all of this, when you have the opportunity to be in front of the players and the clubs, incorporating oral health education and awareness sessions. And this is where the behavior change can start to seep in. Having those initial conversations, exposing players to dental screenings so that they start to realize the importance of oral health on how it affects their general health and sporting performance. Next slide, please. So when we do the screening, there are specific indices which we use, which help guide us. Again, it's very important to understand that the screening is very much just that. We are looking for clear and obvious signs of disease, things which cannot be picked up by a dental, not everything be picked up by just our eyes, which is why they do need to still attend a dentist. So we use ICDAS system, which is International Caries Detection and Assessment System. If you look on the picture on the top right, the two pictures to the right-hand side, which says ICDAS 3 to 4 and 5 to 6, those are the real ones which we are screening, which are easier to screen for and record. But when you look at the images just below them on the X-rays, you can see how large those dark grey areas are. And that's the extent of the decay, and they are not far away from the pulp, from the nerve, which Peter showed you in the dental anatomy at the start. Meaning, if left very long, whilst they may not look very big in the picture, actually radiographically, those are potentially going to cause the players quite a lot of pain and discomfort, and will impact, again, their performance, their ability to perform, their well-being. We also have an indices looking at basic erosive wear examination, so looking at abrasive and erosive tooth wear. Again, the second row of pictures there, looking at patterns of tooth wear, whether it be from, we can from that identify it's from grinding the teeth or from acidity or reflux. And then also we're looking at the periodontal health. So it's a basic periodontal examination, which are those images at the bottom, whereby we measure the probing depths. And again, as Peter showed you on the anatomy slide, we're looking and measuring for bone loss or just inflammation. And that gives us an indication as to the health status of the player's gums and the supporting structure of the bones. Again, we're also looking for the presence of trauma and the presence of abscesses or fistulas and ulceration. Next slide, please. So to start to get into some more practical elements, we know prevention is better than cure, and oral hygiene is absolutely key. We very much appreciate that the environment that professional football players and elite athletes are working in are extremely demanding, and it can make it difficult to integrate oral health and dental attendance, for example, into that. So we want to try and bring in these healthy behaviors, make them aware of the need for, understanding how their diet can affect their oral hygiene, understanding how their training can as well, but also understanding how they can make changes. And with simple interventions such as oral health techniques, this can make a massive impact. And we in the UK use something, there's a Delivering Better Oral Health guideline, which also gives a toolkit, an oral health prevention toolkit, which is evidence-based, and it's very, very helpful for clubs to follow. Next slide, please. So when it comes to dental decay and caries, I mean, we know this, and it's often things which, as we've seen in the research, neglected or missed because diaries are too busy or players are too tired or things get forgotten about. But as a fundamental, we want players to be brushing their teeth twice a day. The studies have shown us that only about 77% of patients or players, the academy players, were brushing their teeth twice a day. And these again are elite professional academy players. So really they are looking after every aspect of their body, but the mouth doesn't seem to be quite up there yet. Brushing, of course, we want with the fluoride toothpaste, and sometimes depending on their risk levels, we may give a higher, recommend a prescription-based higher fluoride content of the toothpaste. And when we're brushing, we want to be spitting out and not rinsing, because we don't want the fluoride in the toothpaste to be rinsed off the teeth, because that is there providing protective effects. We want to be ensuring that they're cleaning between the teeth regularly, and this is done through use of dental floss or dental tape and interdental brushes, of which when we did our study, very few were actually admitted to actually using it regularly. But also we can be using a fluoride-based mouthwash, and always would recommend without alcohol. And this should be used at a different time to brushing. And often when we think about the diets during training, if there are energy drinks, for example, or sports drinks, actually these types of mouthwashes could be used after training, and patients are players are getting changed and after their training sessions when they may have consumed more of these things. And again, trying to reduce the frequency of these refined sugars, of course, where it does not interfere with their diet plans and their training and competition. And also, in addition to the screening which we mentioned, these number of players are at high risk. So as a minimum, we do recommend that they are having a dental checkup in a dental practice with a dental hygienist as well for cleaning, in addition to the use of x-rays where appropriate, at least twice a year. Sometimes these players will, if they're deemed to be high risk, will be needing it 3 or even 4 times a year for checkups. Next slide, please. When it comes to gum health, we can see here on the right-hand side of that picture at the top, which Peter showed earlier, the second arrow on the right, that is where there's bone loss and the inflammation, and the middle picture, there is tartar built up, and of course the picture at the bottom is quite self-explanatory for all the inflammation. And these are all signs of gum disease and gum inflammation. And like we said before, ensuring we are brushing correctly, using electric toothbrushes, correct technique as well, but also things like, of course, not smoking, not vaping. And there's a big interest, and we understand big use of snus by football players. That has a potential risk for not just more sinister things such as oral cancer, depending on the type of product which is being used, but also potentially for periodontal disease. And again, recommending twice yearly checkups and hygienists at least. Next slide, please. When it comes to tooth wear, abrasive and erosive tooth surface loss, there are different factors which can cause this. There are sort of intrinsic and extrinsic, as Peter mentioned before, from gastric acids, for example. We want to make sure that we are modifying how they are looking after their teeth, making sure that they are rinsing with water as best straight after their acidity, for example. But also, like we mentioned before, one of the other really important things which we noted was the tooth wear as a result of clenching and grinding of the teeth. And so seeing a dentist, managing the stress through mouth guards, through physiotherapy, through cognitive behavioral therapy, things like this, which is very, very important, because particularly at such a young age to have so much tooth wear, we want to prevent that from worsening. I'm just going to jump onto the next slide. I'm conscious of time, so I just want to jump through a couple of them. And this is just with regards to the actual acidity. We look at anything below 5.5 pH. We follow something called the Stevens curve. That is when the tooth enamel starts to demineralize and puts us at risk of breakdown of the enamel through acid erosion, which can then result in sensitivity, fractures, tooth decay as well. And this is just, there's a study looking at the pH levels of fizzy, energy and sports drinks and juices as well. And this just gives us an idea of the pH of some of these. If they're being consumed very regularly, as some of them are, you can imagine the damage that this is being done to teeth as well. If we just jump onto the next one, I'm just conscious to jump through. I'm going to just jump onto the next one, actually, if that's all right, after this. I'm going to very briefly on trauma. Of course, we know that there's pitch side management of trauma when something is knocked out. But the other really important thing is to note is that sometimes it can be a very innocuous knock. So on that top right one, you can see that's quite a clear, very large fracture that the player needed a root canal straight away. But on the lower left-hand side, the edge is broken. We take an X-ray immediately after, and then 1 month after the first X-ray, it looks okay. 2 years later, player comes back and there's an abscess which is formed and they're in pain. And on the bottom right, the yellow arrow shows a very small little restoration, composite filling there from a small knock. And 5 years after the trauma, they came in with a massive swelling. So there are very distinct guidelines from the IADT about recall protocols. And that's why it's very important. Even something innocuous, it is followed up with a regular routine review with X-rays to ensure that nothing is seeping underneath that could potentially flare up and cause a problem to the player's ability to compete and perform and their well-being. Just next slide. Just to quickly touch upon, we do often see oral manifestation of systemic disease in the mouth. And as a dentist, often we're the first person to identify this. And whether it be nutritional deficiencies such as oral ulceration, the impacts of stress as well, different infections can present in the mouth, and the side effects of vaping, snus, or smokeless tobacco as well is really, really important. So again, another reason beyond just looking at the teeth, we're looking at the oral health and the general health of these players. Next slide. So you can move on to the next slide, actually, because I'm just unconscious to get some Q&A in. When we talk about oral health, we're talking about putting the mouth back into the body and how important it is and its contribution to systemic health and sporting performance and overall health and well-being of these players. And although acute episodes are very rare, such as major trauma, really we're looking at the long-term impact and the players self-reporting the effect of this as well. And whilst it's difficult to measure, objectively, the impact of their periodontal disease or their VO2 or their speed. There is a lot of evidence looking at self-reported outcomes and impact of oral health with different systems which exist and how it affects their ability to speak and function. And just as a final point, we are here all with a duty of care looking after our players, and their well-being and performance is absolutely central and key to everything that we all do as a team. And we want to, ensure that the teeth help make up that 1% gains that we talk about. And this includes incorporating, sports dental teams, so the sports dentists and the sports hygienists as well, to help with oral health assessments, education as part of the overall athlete care, and collaborating with you and our colleagues here on this call today to integrate sports dentistry with all of you. And hopefully that will help improve the general health and well-being of our athletes and of our football players. And thank you very much.
Thank you very much, Sol and Peter. There we are again. Glad we have some time for questions. I will also ask the audience that's online if there are any questions, and I see one popping up already from Mara Davidson. I don't know if I pronounced that right. Sorry, Mara. The question is, I think, pretty straightforward. Which one is better for oral health, an electric or a plastic toothbrush? And is there any specific difference?
So I'll be recommending an electric toothbrush with a round head with a pressure sensor, and it helps ensure that patients are getting sort of accurate brushing, correct pressures. They're not over brushing to cause recession or wear facets, which can lead to further issues such as sensitivity. To ensure that they're getting appropriate cleaning. Our brushing and flossing, yes, and of course the flossing to clean in between the teeth. The toothbrush is cleaning around the outsides, but we need to get in between the teeth, and the only way we can do that is by using dental floss to clean the contact, so where the two teeth are touching, which prevents decay from accumulating in those areas, often where there's already existing fillings. But also we can use interdental brushes to ensure that the gums are being maintained and clean there as well. And there are additional adjuncts to these things like irrigation, which people can use as well. But it's always going to be the mechanical debridement and cleaning of the teeth as a priority.
Just to elaborate on that point, Mara, I think there is certainly evidence, there's studies written that support electric toothbrushes being slightly more helpful than manual ones. But I think with the flossing can be quite a tricky thing for people to do. So I think if an individual can master it, great. But otherwise, the little interdental brushes are really helpful. And that's just quite an easy manual task to do.
I scribbled down some questions while you're presenting, and this leads up to one pressing question I had. If this is so prevalent in athletes, right? There's to me 3 options, and maybe there are more, but there's 3 that came to mind, and I just want to pose them to you. One, athletes nowadays don't have the oral hygiene that is needed to take proper care of your teeth and your gum. Athletes need to do more than what we generally recommend, because the previous question we recommend to everyone, right? Have an electric toothbrush and do flossing. Maybe that's not sufficient for athletes. And then the question that would follow up is that then the athlete's fault, or do their dentists just give the general recommendations, but they need to go one level up because they are elite athletes and they need special care? So that's maybe a lot of questions in there. But the first one, is it the athlete's issue not taking proper care, or do we don't have the right recommendations for athletes at the moment?
Shall I kick off with that to start with? So yeah. I think ultimately it is the athlete's responsibility to look after their body, including their mouth. But I think it's also the responsibility of the dentist that they are seeing, hopefully on a regular basis, to educate them. And I think it's not sufficient just to say to anybody, never mind an athlete, you need to brush twice a day, you need to floss, you need to use this toothpaste. We actually need to show them, and we need to educate them how to do it. And this is where our hygienists come in, because this is what they're trained to do, to educate our patients, to really look after their mouths a lot better. So I think the initial responsibility is the athletes, but I think it's our responsibility as dental educators to educate our patients, including our athletes, in how to do these things properly, rather than just saying, go away and brush twice a day.
Yeah, but then the second part, and maybe I'll put you to that, Sol, then. Are our recommendations sufficient enough for an elite athlete or a professional athlete or a football player in this case, who uses more sugary drinks, who is traveling a lot, who might have a low immune suppression or whatever due to the high level of exercise? Do we need to have one level up of recommendations for their dental hygiene if we...
Yeah, so it's a really good point. And I think we are looking at a group of people who are essentially at high risk. So, they do fit into our high risk category of our patients who are high risk, who are not athletes. And we take different approaches with them. And that includes, they do need to be seen professionally more frequently. They do need more tailored oral hygiene advice and education. They do need more, tailored nutritional advice as well, and the impacts of that. And I think also ensuring that the clubs and players, medical teams around them, we don't expect the doctors and the physios to be dentists and to understand that. But I think understanding that it has a role to play, they can make a contribution to helping with that behavior change. There's a lot of evidence to show that we need to do higher recalls, but I think also the dentists need to understand that you're working with athletes, and we need to understand the parameters which come with that, and the difficulties and the lifestyle and the access to care, and it very much does need to be tailored to them as athletes and football players. So yeah, we can't just see them as a average patient who just gets, I say average and I say routine, but definitely we need to be very specific to their environment and to what these people do. Understood.
We have a very specific question in the comments. It's about your experience with, and they already apologized for the autocorrect. Let me put it here. Maybe you can figure it out a bit better than I. With a number 8 teeth with a local chronic infection and chronic infection of the foot. So it seems to be questioning whether there could be an association between an oral infection and an infection somewhere else. Can you comment on
that? We are dealing with a demographic of people here who have their wisdom teeth, the eighth tooth, erupting during this time. So between sort of 18 and 30 years of age, if people get wisdom teeth, then they get them during that age range, if you like. I think what happens here is that the wisdom tooth tries to come through, particularly the lower wisdom tooth, tries to come through, and it doesn't come through completely because there may not be quite enough room for it. And as a result of that, the gum gets inflamed, infection gets into the system. And so, yes, potentially it's possible that the infection could then materialize in a foot or in a toe or something like that. I have to be honest and say I've never ever seen that or anything, but potentially, yeah, I'm sure that could happen. And there are many cases, anecdotal evidence, where athletes have missed a final or failed to win a medal because of an infection around a wisdom tooth. And it may seem that the simple answer is, well, let's take all their wisdom teeth out. But actually, taking wisdom teeth out can be quite a major surgical procedure. and the recovery time from that can be quite a long time in terms of not a few days, but weeks or months. And so you have to balance up between whether you are going to treat that athlete conservatively, i.e. maybe using a particular mouthwash, saltwater mouthwash or a chlorhexidine mouthwash, something of that sort, to ease the infection that's there, or whether they are then going to go and have surgery to have the wisdom teeth removed. But it's the removal of wisdom teeth now is not something that we jump straight in to do. And particularly with the athletes, we're very aware of their schedules and the fact that the recovery time can be quite prolonged.
I think just to add to that point, if I may, I think that also emphasizes the importance of the screening and their attendance to be able to identify when these teeth are coming through, so that the appropriate advice can be given to these athletes and the players. Because, like Peter said, the age range that the wisdom teeth are coming through is exactly this age range of our professional football players.
Understood. Yeah. That's why you are on the call and not me explaining this, because you understood the question and answered that one brilliantly. For the sake of time, I think we need to leave it here. There's one more question in the chat. We will forward that to you, Peter and Sol. It's on specific nutrition. We're probably going to deal with this in a future webinar also, Mara. So if we can't answer it now, we will answer that in the future. Leaves me, Sol and Peter, to thank you very, very much for this hour. Very insightful. I'm sure there's more to talk about this and more to say about this, given that you had to rush through a few more slides so in the end, which means 1 hour is not enough. But thank you very, very much, and also for the questions. And hope to see you soon, probably in another webinar on something more specific.
Thank you. Yeah, thanks very much for the opportunity. That's been really interesting and helpful. Thank you, Evert.
Yeah, thank you, everyone. Thank you, Evert and Zoran, and to your colleagues for joining. Thank you.
Great. And before everybody logs off, our next webinar, so we're kicking off after summer again, is on October 27th, as usual, Monday, same time. And we're going to talk about pain management. We've talked about pain management before, but more from the pharmacological standpoint. And now we're going to talk more about it from the practical standpoint, how to deal with it when players need it, and look at the pros and the cons of pain management in that sense. So hope to see you soon. And once again, thank you, Sol and Peter, but also thank you for everybody who was online to join us for this hour.
Thank you. Bye-bye now. Bye-bye.
Bye-bye.
Bye.